Welcome everyone to VJSocial. We're in the middle of EHA and looking forward to some great sessions in CLL and lymphoma. And our focus has been around how to use Twitter generally, but also more specifically during Congress, whether in person or virtual, which we're doing these days. I'm joined by Toby Eyre from Oxford. Toby, I wonder whether firstly you could just give us an introduction to yourself and how you got and how you use Twitter as a kind of tool for your professional communication education.
Thanks very much for the introduction. Yeah, so I've been on Twitter just over kind of 3 years or so. Was encouraged by my good friend and colleague Graham Collins, who many of you will know and heard of. He's a bit of a Twitter guru, and he's been slightly addicted to Twitter for about the last 7 or 8 years. And he said to me kind of 3 years ago, "Oh, Toby, you've got to get on. You've got to, everything's happening on there. Everything medical's happening and so forth." So I think I was slightly guilted into it initially, but then kind of very quickly caught the bug. And yeah, I mean, I find it just a really valuable educational resource. I find it great fun, very engaging, and just has kind of multiple benefits, both personally for me, but also just kind of find it just a great resource to be able to kind of connect with people and engage with the latest medical data and lymphoma CLL work that's being produced all the time and presented. You can really have your kind of finger on the pulse when you're on Twitter, which is what I really like.
So we're coming up to some great sessions at virtual EHA. Obviously, it's a shame we can't get back into in-person meetings, but it's clearly there's a lot of great presentations. There is data coming through, and Twitter is a great tool to share and engage with that. What are you seeing, and what are you looking forward to coming up in CLL this year? And what do you think will be the trending topics on social media?
Yeah, so I mean, we've obviously seen over the last 24, 48 hours, some really nice data kind of come out in lymphoma and CLL. I suppose specifically for CLL, lots of very interesting data, but 3 randomized clinical trials have been presented for pretty much the first time in the last 48 hours. And so those topics around the Alpine study, around Elevate RR relapsed refractory CLL study, and also the GLOW studies just been presented today. So those 3 clinical trials obviously will cause a lot of conversation, plenty of debate on Twitter, which can be interesting to see people's opinions, people's kind of ideas around the interpretation of the clinical trial data. I think seeing other people's views on the data also makes you kind of reanalyze your own views on what you think you've seen, and it might help you kind of reflect on the data in a different light, perhaps. So I certainly find, just in general, that a very useful experience. In terms of those 3 clinical trials, though, of course, they're potentially all practice-changing studies in their own way, and so they're really valuable to really kind of take time, think about. And there are certainly people's views that I really value on Twitter that I'll follow and kind of reflect on. So yeah, just in general, very, very helpful kind of medium to evaluate new data by.
But for those new beginners, intermediates coming in to use Twitter, what's your advice in terms of following and retweeting or interacting with some of the the leaders who are using Twitter and also presenting big studies?
Yeah, it's a good question. I suppose it depends on your view on how you want to use Twitter, in terms of whether you just want to use it in a very kind of light touch way, whether you just want it there purely for information to observe, or whether you really want to kind of dig deep and interact and do a lot of tweeting and so forth. And obviously that will suit certain people's personality, certain people's kind of just beliefs about how Twitter, social media can be used. I think kind of advice that I'd use is, if you really want to get stuck in, just kind of go for it. Make sure you kind of follow people who write things that don't irritate or annoy you, that you're kind of enthused by and want to engage with. But also don't shy away from people who provide opinion, because actually that's quite valuable. One of the things about Twitter is obviously you're kind of sort of free to say what you like about something, and that's kind of one of the beauties of it. You can have kind of debate if you wish. But I suppose one of the really good things about Twitter is you really get to use it as much or as little as you want to. You're in total control of who you follow, how much you write, what you engage with, what you don't. And I think that's a really kind of valuable thing, that it provides that kind of level of flexibility for individuals to decide how and when they want to use it.
Now, I can see you've been doing some tweets in recent days. What's your advice in terms of kind of putting together a tweet? How do you approach it, and how often do you do it? And what are some of the kind of tips that you give to people who may not have put some tweets together? The anatomy of tweets. What should you be including?
Yeah, it's a good question. I mean, I don't think I've ever had any kind of formal feedback on my tweets. So some people might think they're rubbish, other people might think they're good. So, but I suppose I think I've kind of learned a little bit not to kind of overload tweets with information. Some people like long threads. My sense is that most people like kind of bite-sized bits of information. I think pictures and images of either presentations or kind of Kaplan-Meier curves and so forth can be quite useful. I think people like images. I also think kind of asking open questions within tweets can be quite a nice thing to do, particularly when there's something that you haven't really fully got the answer to, and there's kind of a debate to be had about a topic. Actually, kind of presenting that out there as an idea for people to think about is quite nice. I think kind of using appropriate hashtags can be quite valuable. Obviously, when there are congresses on, tweeting with the relevant hashtags for congresses can be quite valuable. So, some people do that more than others. Also, some people kind of tweet with hashtags for different drug names or disease names, which I don't know. Actually, I think that can be valuable. I think some people do follow certain things like that. I wouldn't be able to tell you definitively whether that's of huge value, but I think certainly kind of bite-sized information, images, open questions can kind of stimulate interaction and debate.
Hey, Meza, nice to see you. Got Toby here. I wonder whether, Toby, you could fire some questions around some of the areas we've been talking in CLL and lymphoma, and see what Meza's view on Twitter and more generally and some of the data coming out at EHA.
Sure, thanks. Hi, Meza. Can you hear me okay?
Yes, I can.
Brilliant. Well, you're the kind of perfect person to this, because there's lots of interesting CAR T data, which I know you're obviously an expert of, and also some really interesting CLL data, which of course is also one of your kind of fields of expertise. So you're perfect here. Can I ask you just your views on the differences between the Alpine study results and Elevate RR? Obviously, this is going to be a kind of big topic people are going to talk a lot about over the next kind of coming months. How do you see the kind of relative differences in the studies? What are your kind of key take-homes? And also, I'd be really interested to know about what you feel about just the general study design, because obviously there's some nuances there between the two studies. So that's a few questions, but interested in your views.
Yeah, of course. I think that's one of the probably more important questions that's coming up with the EHA meeting. And so first of all, they're both non-inferiority design studies in the relapse setting, but looking at different endpoints. Of course, the Elevate study looked at PFS non-inferiority, and because of that, the study had much longer follow-up in order to achieve the number of events to be able to look at that primary endpoint. So I think the first thing to remember is that the duration of follow-up between the two studies is very different. Alpine had overall response rate as non-inferiority and superiority, just CR and PR. One of the common questions that people asked about the design is why not our PRL? And the answer was that it was a regulatory requirement not to include PRL in that primary endpoint. So I think that's important to kind of pay attention to the primary endpoint. And then of course, each study has secondary, or the hierarchy of design, secondary endpoints that they could also look at from the different AEs. And of course, in case of Elevate, I think they had overall survival as one of the secondary endpoints. In Alpine, they had PFS as a secondary endpoint, although it was an event-based endpoint. So the curve that was shown in the Alpine study was kind of a descript. I don't think they've reached enough number of events to kind of look at that curve. I think the take-home message, the other difference is that the Elevate study included only 17P and 11Q patients, and Alpine was kind of open to all in the relapse setting. And we can talk maybe about that a little bit, what it means in terms of the efficacy comparison between the two. To me, the take-home message is that both second-generation drugs are, in terms of the efficacy, they're good. They're not worse than Ibrutinib, maybe in terms of Zanubrutinib, and looking at the endpoint that they defined, it looks even, it did meet the criteria for the better overall response at least. And we saw that the AEs of interest are in general less commonly seen in the new generation drugs. We can talk about the specifics of AFib and, maybe neutropenia being a little bit more with Zanubrutinib, but did not translate to actual infection. So, the Alpine study was an interim analysis. We need longer data. We need to kind of continue to follow the PFS curve. And but I think the message is that I don't think we can kind of leave with a conclusion of one of the second generation BTKIs is better than the other one. I think it's always impossible to compare across the trials. But to me, if Zanubrutinib becomes approved for CLL, I think that's another great option. But I think there are specifics that we can pay attention to. The fact that Elevate study only included 11Q and 17P, I'm just focusing on 17P, I think around 60% or so of those patients had some P53 abnormality, if I'm not wrong, maybe more. So I don't know. If we at some point decide to look at the efficacy, I would think if you don't see a difference in a high-risk group, you're less likely to see that difference in all comers. So in a way, the fact that Elevate included more high-risk patients and yet we didn't see a PFS difference, if anything, it argues that if you included more standard risk patients, you would be even less likely to see that difference. And in Alpine, it was all comers, and the curves, at least by description, they look, I don't know, this is maybe thinking a little bit too much, but because I've heard discussions about the eligibility, I wanted to kind of...
It's interesting, isn't it? So how do you think you would, assuming the Zanu gets a kind of FDA license approved on the back of this study, and you can use the agent here in the same setting, so you've got a choice of effectively 3 covalent BTK inhibitors in relapsed refractory disease. What do you think would be your kind of agent of choice, and why would you use certain characteristics? Would you look at the genetics, for example, to only consider Acalabrutinib in 11Q and 17P, or do you think you would go broader with that? What are your kind of? I'm sure these discussions will happen, won't they? And do you have any strong sense of what you might use and why?
I think at this time, again, remembering that Zanu is not yet approved, but I think at this time, I feel confident that one of the second generations would be my preferred choice over Ibrutinib. I think, we have now enough data and evidence. There's always longer follow-up with Ibrutinib, and that's true. But, this year at Elevate TN, we saw specific information on 17P on frontline. We looked at those curves. So I think for me, it's either Acala, and when Zanu becomes available, it's either Acala or Zanu. Which one do I pick? I'm not a believer in that kind of having a head-to-head trial for every single. There will be more drugs than patients soon. So I think it's okay to have 2 great drugs, but there are specific clinical scenarios that you could use one of them and maybe not the other one. We all know about the PPI and the absorption issue. We all know about the, I don't know if the BID dosing versus once a day dosing would be an issue. Headache has never been a problem for my patients, a reason to, I shouldn't say never, but most of the time it's not a reason for me to stop Acala. I think they're both great drugs. I don't have enough data or a reason to believe one is better than the other, but I discuss both with patients. And again, there are specific factors that if I have to, mention, I will mention. And I think the ones that I mentioned are probably the relevant ones. But I think it's fair to say that second generation BTKIs are my preferred choice over ibrutinib at this point.
Yeah, I mean, I think we're seeing now a kind of accumulating data of the second generation BTK inhibitors just generally being safer, particularly from a cardiac point of view. Although I was actually interested, the Acalabrutinib study, if you look at the AF and the A fibrillation, A flutter rates in the Acalabrutinib treated patients, actually it's still somewhere around, in this study, it's somewhere around about 10%, interestingly. So, whilst we do believe these drugs are kind of cleaner in general, there's still a proportion of patients who are developing AF, which is interesting. And actually, perhaps the zanubrutinib rates look a little bit lower, but obviously, as you mentioned, the follow-up's short and it's very hard to compare across studies. I'd be interested in your views about just this idea of presenting survival data at interim analyses when the overall response rate is the primary endpoint with the Alpine study. Why do you think that was done at this point? And this is a slightly cynical question, do you think we would have seen that if there was no difference, for example, at this point? Because it seems really early to me.
Well, Alpine, as one of the co-investigators, full disclosure, Alpine actually, the PFS was one of the secondary endpoints for non-inferiority. OS was one of the secondary endpoints for Elevate. So, the curve was shown, but it was also mentioned that this is an interim analysis. So the OS was not the curves were interesting, right? I mean, they're separated, and I don't know the answer to that question, whether or not it would be shown if they were like overlapping. But I think it's good to, as long as we understand that this curve needs to be followed and the number of events are not there, I think it's interesting to look at even as a description, looking at the shape of those curves. But I agree with you.
I suppose in my view, you do a plan. Maybe I've got this wrong, but in my view, you do a pre-planned interim analysis based on the primary endpoint, and rather the pre-planning relates to the primary endpoint. It kind of must do, and then it's just interesting that the other events were also presented, which is interesting. Given that you're an investigator, I'd be interested in your views on blinding of studies like this. And whether you think that studies where, in effect, what you're trying to do is show drug A is safer than drug B and equivalently efficacious. That's what kind of, in essence, both studies are sort of aiming to do. Do you think these studies should be blinded to the investigator? Because we all know some of the biases involved in opening a study where you've kind of sort of been told the hypothesis is that drug A is safer than drug B. Do you think that influences people's AE reporting and so forth? What are your thoughts there? Or indeed discontinuation rates?
I think it does. Yes, absolutely. I think the standard way and right way of doing it would be blinding. I mean, for logistical reasons, we all know that may not always be possible. I think it also depends on the type of AEs that we're looking at, right? I mean, AFib is probably less affected by that blindness versus like if arthralgia reporting or maybe even hypertension. I don't know. I mean, there's anxiety. And so ideally it had to be blinded to the patient and the investigator. But I think, again, seeing what we're seeing in the cardiovascular kind of, cytopenias, things like that, they're less likely to be impacted by that.
Yeah, interesting. Can I ask you about Elevate treatment naive? We've obviously, Jeff Sharma presented a very nice update of that. We've now got 4-year follow-up there. And it's intriguing, isn't it? Because we've got this, it would seem to me, increasing difference between Acala monotherapy and Acala plus obinutuzumab. Now, of course, we all know when you add obinutuzumab, you clear the marrow better, you get higher CR rates. What's your kind of take on that difference? Do you think that's clinically meaningful? Do you think that will influence the use of the CD20 antibody? I guess there's a trade-off here, isn't there, between the additional efficacy, disease control, and toxicity. What are your thoughts here? Do you think it will change practice at all? Well,
I have to be honest, I don't know what to do with the data yet. I mean, we we all thought that the story of CD20 antibodies and BTKI is done, and we don't have to go back to it. And of course, the initial report of Elevate TN, so there's some difference. Let's look at the longer follow-up, and here we are, and that seems to be getting more real. I agree, it's a trade-off. I don't know if at the end of the day, it's not the primary analysis, the numbers. There is a risk of adverse events. We living in the COVID era and the efficacy of vaccines and things like that.
Yep.
I personally still don't think that adding a CD20 antibody to BTK inhibitor is going to be my practice. So, I admit that the data is data and it's there, but I would still continue. Now, of course, I will present that to patients, but my suggestion for them is to go with monotherapy with BTK with Acala. But that's just maybe looking beyond the study and kind of risk-benefit ratio with considering other factors.
Yeah, great. And then the final randomized study obviously has just been presented today. I don't know if you had a chance to catch up with this yet, but the GLOW study has been presented. So Ibrutinib venetoclax, Ibrutinib for 3 months, then a year of Ibrutinib venetoclax, compared with our old friend chlorambucil obinutuzumab. So a kind of older group of patients. I mean, what's your take on that study and that combination, for example, compared to the outcomes from the CLL14 study, for example?
Well, in general, so the combination, we all think that it will be a big part of the future for CLL. I think we have now different studies trying to look at that combination. We have the Captivate now, we have the GLOW, we have single institution studies from MD Anderson and others. Mm-hmm. We have intergroup studies in the US with the combination plus obinutuzumab. To me, of course, it's great. I mean, these studies are important to look at the primary endpoint and depth of response and things like that. But the clinical question for me is that, is it better than a monotherapy with BTK, considering that fixed duration aspect of this combination is absolutely important and attractive, but what about comparing it to, as you mentioned, the CLL14 kind of Venobino? I think we do need head-to-head studies looking at those treatments head-to-head before we make a decision. I think studies like CLL17 study or similar studies with other BTKIs that are planned will probably give us that answer. It's always, I don't know. We'll see if the combination becomes one of the options for standard practice, but I am not sure if I'm convinced that I'm ready to use that before seeing a head-to-head study comparing it to VenG, for example.
No, absolutely. And as you mentioned, CLL17 is going to be a very important and valuable study there. Hopefully also that study will give us some idea about, as you say, sequential monotherapy versus combination therapy up front, and how that will ultimately work itself out. And who knows, there might be some good kind of real world data that will help in that regard in the longer term as well. What are your views on kind of agents to use after a BTK and BCL2 inhibitor? Because, we hear this kind of talk about, it's going to be mutation status guided. We're going to check for BTK mutations and use a BCL2 inhibitor if you've got one, and vice versa, right? Do you think that's going to be a reality in a lot of places, or do you think people are just going to plump for whichever one they want and kind of then reverse it if it doesn't work? Or how do you kind of see that playing out, not only in academic centers but kind of across the board?
I mean, just patients who are double refractory, or not? Just
so if you get, I should be clearer. If you get a BTK and BCL2 inhibitor up front, so like GLOW or Captivate, one of those two studies, and then progress. So that's obviously a kind of you're kind of entering sort of evidence-free zone really at the moment. We've seen a small bit of data from Captivate of Ibrutinib retreatment, but very little. What's your sense? Do you think we'll be guided by mutation analysis, or do you think we'll just be guided by kind of clinical response and trying one or either class of drug?
I think that's a very important question, and that's why we need the randomized trial, right? Because yes, having that initial response and MRD eradication rate is great, but what happens later? I mean, that's why, like an overall survival, what is it the sequence or is it the combination? I think it depends on when you have that progression. If somebody has disease progression while getting both drugs, that's definitely the worst case scenario, right? So your first and second generation BTKIs are out, your venetoclax is out, and you're left with pretty much nothing reliable as a standard of care option, right? Who knows how PI3 kinase inhibitor is going to work in that setting? They're not studied for that setting. Yeah. And then you're left with clinical trials and things like that. So that's the nightmare. And thankfully that's not a very common scenario. Then the situation is, what if you stop treatment and 3 months later they have progression, right? That is also not a good situation. I mean, for the BTKI piece of it, it may not be very surprising, but we know that early progression after venetoclax stopping is not necessarily a good thing. It means that they didn't probably achieve an MRD negative status. So I think that remains to be a really unmet need, pretty similar to really relapsing on treatment. For later relapses, it's probably much easier. I mean, you can always go back on BTK inhibitor because you stopped it, right? So we know that for many patients, when you stop Ibrutinib, or BTK inhibitors, even for a short period of time, you start seeing some growth. So you can always go back on BTKI. I would definitely check for resistance mutations in my practice. I don't know how that would translate to the community practice. Probably not great. We're still having challenges with getting the standard FISH panel tested or IGHV. So I don't know how widely that will be picked up by the community. And then you can also, depending on the timing of your relapse, you can also look at BCL2 inhibitor as monotherapy. I would probably not go back on a combo. We try combo for a fixed duration. If it really doesn't work, why would I go back to combo? I would probably then start with monotherapy. And again, depending on the timing, as you said, this is totally data-free, and I'm kind of coming up with ideas, but that's the nightmare of anybody who's working in this area, that if you're using your best drugs together, and what if you have a situation that you have to use something else? So,
yeah.
No,
of course, absolutely. And I suppose you would hope those scenarios would be few and far between, but when they do occur, of course, yeah, absolutely. We're basically in a kind of dual resistant area, as we would be if you use them sequentially and patients progress through, but probably even higher risk because of the nature of that progression. So it's an interesting kind of area that will be explored, no doubt. And then just perhaps kind of finally, if we've got time, Charlie, just to kind of talk briefly about a couple of studies, a couple of CAR T cell studies that have been presented in lymphoma. So we've seen an intriguing analysis, and we've seen kind of versions of this before, but we've seen an intriguing analysis of a study called the Scholar-5 study. Again, I don't know if you've had a chance to see this, but this is basically a kind of propensity matched analysis of patients with relapsed refractory follicular lymphoma, generally treated outside of clinical trials, or they included some of the idelalisib clinical trial patients in their study, and then compared with the Zuma-5 study patient population from the phase 2 study. The control arm, so to speak, so the kind of standard of care arm, was very heterogeneous in terms of lines of therapy and what was received at different lines, as you might expect. But we see basically a fairly striking progression-free survival difference, both overall and when you divide by things like lines of therapy, but also a difference in time to next treatment, and indeed, intriguingly, a difference in overall survival. Now, clearly there are some kind of issues here in terms of the design of this kind of study, because perhaps some of the control arm may not be clinical trial style candidates. And I'd be interested in your take on both this kind of style of analysis. We've obviously seen it before with the Scholar-1 study, and also in poster form, there's the Scholar 2 study, which is the kind of mantle cell version of this study, comparing to the Zuma 2 study. So I'd just be interested in just your take on this and whether you feel this provides adequate level of data to kind of take the place of randomized clinical studies in a kind of challenging area to do randomized trials. Just interested in your views.
Yeah, no, I have not had a chance to see that data, and so to be so yeah. But I mean, in general, I don't know. It's very difficult to. First of all, you're looking at two very different types of treatment. I mean, really, even on a clinical trial, it would be a challenging comparison. You have a one-time treatment versus an ongoing kind of a maintenance type approach with very different safety profile. One really accumulating over time. The other one, you have to deal with it for a couple of weeks and you're done. So I don't know. And again, I repeat that I have not seen that data. So my comments are in general related to comparing different treatment modalities, that we're seeing more and more of these type of analysis, because as you mentioned, doing clinical trials in this setting would be extremely difficult. I don't know. I don't think I find them very useful clinically. Maybe, I mean, if it gives you the benchmark to compare your novel agent, and even that would be important. But I don't know how to compare a type of treatment that gives you a complete response rate of around 20-something% if you take a drug for 6 to 12 months to something that you do a one-time treatment and you get it, so it's very difficult. So I'm not sure if I would be I would find them very helpful. But
yeah, no, I'd agree with that. And I think one of the challenges here is you have this issue with unmeasured confounders. So patients might have been enrolled in a study like this in the control arm that clinically you might not think were necessarily trial fit, or certainly CAR T cell fit, but they fit the kind of broader eligibility for this kind of study. Similarly, there are some clinical trial eligibility style style parameters that perhaps are unmeasured here, that clearly you need to have good renal function, good hepatic function, for example, to go into a clinical trial, whereas within the control group here, you may not have needed all those same kind of precise parameters. You may not have needed to be trial fit, if you see what I mean. So I think that's kind of one of the other issues here. But nevertheless, it's clearly showing progression-free survival advantage that's fairly striking in this study. So we will see if there is a randomized study in this kind of space, which, as you've mentioned, is challenging to actually kind of perform and design. And that was obviously discussed at the late-breaking abstract session. Okay, well, we've talked for about 35, 40 minutes.
Which is great. I wonder whether I could just kind of close off. And, I'd put you as two rising Twitter stars. You're using it in your practice. You're learning as you become more sophisticated. I wonder whether you could just, maybe Toby first, why, for those people not using Twitter or not looking at it or not really actively engaged, what around Congress, what should they be doing, and how would you encourage non-users to dive in?
Well, the first reason I got involved in Twitter, or one of the reasons why I did, was I went into work on Monday morning, and a couple of people who'd been on Twitter and knew loads of stuff that I didn't know, and I was like, wow, this is I don't want to be in this position. I want to know what's going on. So how would I use it? Well, as I mentioned kind of at the beginning, beck the people who are active on Twitter, who you want to follow, who you think are kind of providing tweets that are both educational, accurate, reasonable, thought-provoking, thoughtful, and get stuck in as well. I mean, one of the other things I didn't mention is, obviously there are various kind of video media that are quite useful as well. So, VJ Heme, VJ Onk being an example. There are others, of course. and actually they can provide some really valuable little videos, little snippets of people who presented their data, but in a short video might give a kind of slightly alternative view on it, or perhaps touch on something they haven't gone over before. So I find those videos quite useful. But yeah, in essence, kind of get stuck in. You quickly kind of, if you get involved and engage with it, you quickly find out how it kind of works and who to follow and things. So I wouldn't say I have any kind of, absolute bespoke advice for people, but if you want to get stuck in, then go for it.
Ajay, what's your take, and how are you using it to advance your network and your practice?
I mean, I second everything that Toby just mentioned. I mean, to me, it's just fun. When a paper comes out and I see like it. We talked the other day about there were like curves about how to tweet and what is a standard. I would say I kind of like sometimes that the paper comes out and maybe Toby retweets and said, I don't think so. I mean, that gives me an idea of, okay, that's how people are thinking about study that's out. I mean, that was an example, of course, right? I mean, I don't remember an example, but I mean,
I'm not going to tell you which drug that was.
No. I mean, like you follow people that you trust or you care about their opinion, and sometimes you can hear things that they would normally not say in a plenary session or so it's kind of a way of finding out what's going on in the field without really spending too much time. So that's the part that I like most about Twitter. And by no definition, I'm a professional on it. I mean, I don't even think I'm pretty amateur. I don't really tweet a lot but it's just fun. I mean, I learn about things and you talk about things and you get feedback and people actually read what I say. So I think it's but yeah, there are, of course, you got to be responsible. And, we talked about the fact that you have to always think about the fact that your audience is not necessarily your academic colleagues and they're more there. But that to me, that's just being in the mood of the field and see how everybody thinks. I think that's the most important piece.
I totally agree with you. Your audience is not just necessarily controlled by you. So, and you've got to be sensitive to the fact that actually there is a broader audience, and actually there's a wisdom, isn't there, in terms of how much to engage with people on Twitter who, I guess there's three different groups actually. Primarily, there's colleagues, national and international, who you may want to debate with, but also there's challenges in terms of making sure people debate sensibly with limited characters and the potential risk of misunderstanding. We all know that that's a potential issue. So there's some caution and wisdom involved there. There's also patience, of course, and that can be challenging in terms of engaging on a level which is valuable and helpful and so forth. And then actually one of the groups that I find kind of very intriguing is obviously there's industry there as well, or biotech. And certainly the way they engage is different. And they're quite often wanting kind of opinion in the public domain about kind of agents that perhaps they're particularly conflicted about, or they have a particularly strong view on for, a number of potential reasons. So there are challenges that exist about how you best go about kind of navigating that. Be a little bit careful. You can't undo a tweet sometimes. And I think, but also don't necessarily just kind of shun people because you're kind of worried about the interaction. But I think you get a feel for it and learn a bit about that as time goes by, but it does present sometimes some challenges.
Think twice before, but I think just keeping it honest and being, enjoying it and being, transparent. And but look, it's been a great chat with both of you. Hopefully, the next day or so with CLL and lymphoma. There's some new things, both the presentations at EHA, but some of the conversations on Twitter and social media. So look, thanks both very much for coming. Let's loop back and see whether anything pops up on the radar. See you very soon.
Yeah, pleasure. Thanks very much.
Bye, guys. Welcome, everyone. We're joined today by Matt Davids, and I'll get him to introduce himself in a second. These Zoom sessions are really for us to understand what's happening at EHA around CLL and lymphoma, and really to look at it through the prism of Twitter and social media. So welcome, Matt. I wonder whether a brief introduction to you and your life on Twitter, and then we'll maybe kind of dive into some of the abstracts coming out of EHA.
Sure. Hi, Charlie. It's great to see you. So I'm Matt Davids. I'm at Dana-Farber and Harvard Medical School in Boston, USA. And although it's a little sad not to be in Europe this summer, so celebrating with you guys another great EHA meeting, I'm glad we can use technology to connect here. Basically with Twitter, I was kind of dragged into Twitter a couple of years ago. I wasn't enthusiastic about it initially because it was just another thing to have to check. But I have to say it's really grown on me over the last couple of years, and I've found it to be more useful than I anticipated it would be. And so I use Twitter for a variety of different things. I think sort of in between the major meetings, it's for me a great way to kind of keep up with some of the latest data and articles that are coming out. I felt like before Twitter, sometimes a new paper might be published and I might go a few weeks before I even noticed that it came through. And now, as long as I check in on Twitter every day or so, I can see as soon as a new paper comes out and then get some of the perspectives of some of the other experts and folks. So that's always very helpful. And I find Twitter particularly helpful though at these meetings like EHA, ASH, really as a way to highlight work of others and my own work, and particularly if there's a big session coming up to let people know about it and let them know I'm enthusiastic about it, and then begin to provide my perspectives, and even to do that in real time and to interact with so many different people. And it's really a diverse array of people on Twitter, anywhere from other folks in academia, but community oncologists, even patients and industry and so forth. So it's really, it's nice. And, one thing I would say also, to maybe some junior investigators who might be out there is that Twitter is a real leveling force, level playing field, so to speak. So, I find it helpful that if I want to interact with a very senior person, that's fine. If I want to interact with a more junior person, that's fine too. And, it's a great way to kind of, if you're on the more junior side, trying to make a name for yourself to get out there and provide your perspectives and ask questions and really interact with the field. And I think that's actually been particularly helpful in the last year or so, since people have not been meeting up in person during the pandemic. It's been a way for junior investigators in particular, I think, to have a voice in the field. So I guess those are my initial thoughts on Twitter.
We'll delve into a little bit more later, but I wonder, let's turn to EHA and some of the trending topics in CLL at EHA this year. Firstly, perhaps give us your views on, there's been some kind of BTK news, the Elevate and the Alpine studies. What are you seeing? What's your take on these two trials, how they're designed and how you can compare them?
Yeah, so I think this meeting at EHA and then also ASCO that we just had in the US really have been, I think, a breakout for the second generation BTK inhibitor drugs. Almost reminds me of 3 years ago or so at the 2018 ASH meeting when we really saw Ibrutinib taking center stage, where it was defeating all of the great chemoimmunotherapy regimens in all these large phase 3 trials. And so now we sort of have an analogous situation. We have these second generation BTK inhibitors that have come along. Acalabrutinib has been approved in CLL for a couple of years, but there's been this lingering question of how would it really stack up head to head against Ibrutinib, since Ibrutinib is a great drug and has helped so many patients. And we've all been eagerly awaiting the data from the Elevate RR study, as well as now the Alpine study with Zanubrutinib. And we saw the Elevate RR at ASCO, so I'd say we've had a little more time to kind of ponder it and process. Certainly it's a very encouraging study. Amazingly, the efficacy of the two drugs was really identical, a hazard ratio of 1.00 in this high-risk relapsed CLL population. But it really did highlight some of the differences in the toxicity profile of the two drugs. Significantly lower rates of atrial fibrillation with Acalabrutinib compared to Ibrutinib, less hypertension, arthralgias, and several other effects. We do see some of the things that we're aware of with acalabrutinib, like headache, which was more common with acalabrutinib versus ibrutinib. We have to be mindful that acalabrutinib is a twice daily dosing versus daily with ibrutinib, which is convenient for some patients. And, I think that in general, it's a helpful data set. For me, it was influential, but, I think that there's still certainly a role for both drugs. And the Alpine we just saw, so it's a little fresher, but also a little bit, we're still kind of processing it. It's a very early look at that study. One difference actually with the Resonate RR was that it was a study powered off of a PFS endpoint. So it actually took several years for that study to mature, whereas Alpine, the primary endpoint was overall response rate. So this was actually a fairly rapid readout from the Alpine study. And I think, what was surprising to me from the presentation was that we actually did see some potential efficacy advantages for zanubrutinib over ibrutinib at this early time point, both in terms of a higher overall response rate, as well as potentially a longer progression-free survival. But, it's a little hard to tell from a short presentation, some of the details there. So, for example, I believe this was an investigator-assessed response rate, and I think there's an independent review committee that we're going to need to see to make sure that that holds up. Also, we don't know the details of what the progression events were in both arms, the ibrutinib arm and the zanubrutinib arms. That's going to be helpful to see. But certainly, I think at least the safety analysis was very robust and favorable for zanubrutinib. Very low rates of atrial fibrillation with zanubrutinib, also less hypertension and so forth. You do see a little bit more neutropenia, which we've seen in other studies. So that seems to be a real signal with zanubrutinib versus ibrutinib. But again, I think the Alpine study is very helpful for zanubrutinib as it moves toward an FDA approval in CLL, likely soon. And it's going to be great to have all these different options for patients. Even I think a harder distinction to make is going to be between acalabrutinib and zanubrutinib. But there are some differences around the toxicity profiles there and drug-drug interactions and so forth. So I think it's going to be great for CLL patients to have really all three of these as options.
Fantastic. And another study that's been reported on at EHA, the GLOW study. Give us your take on that and perhaps how that links through to a further readout on the Captivate study.
Yeah, so this is another eagerly awaited study, the GLOW study, because it's the registrational trial for the ibrutinib plus venetoclax combination therapy. So this is a time-limited 15-month combination in the frontline setting. And I think a nice thing about the GLOW study is that it's a real kind of CLL population of median age is 71, a lot of patients with comorbidities. And so the control arm is chlorambucil plus obinutuzumab, probably not the most powerful control arm, but nonetheless, it certainly was a standard of care when that study was designed. And so it's useful to see, how these older, frailer patients are doing with ibrutinib plus venetoclax. I'd say that so far what we've seen from GLOW, does look encouraging that it's an active regimen and reasonably well tolerated. It's certainly better in many ways than chlorambucil plus obinutuzumab. But I think one thing that has emerged from the early data set here from GLOW is that the combination of ibrutinib plus venetoclax does seem to have more toxicity in that older CLL population compared to what we've seen in the younger patients on the Captivate study, in particular in terms of rates of neutropenia, infections, and cardiovascular issues. I was surprised to see that there were a few cardiac deaths in the ibrutinib venetoclax arm in GLOW, a couple of which were relatively early on in the first 3 months. And those were not seen in the obinutuzumab chlorambucil arm. So it's small numbers. There's no difference in overall survival between the two arms, but it's certainly a signal that we need to keep an eye on. But I think overall it's encouraging that this is a positive study, GLOW. I think it will lead to registration for ibrutinib plus venetoclax. And then I think the question is going to be, can we apply this GLOW data set to the younger, fitter population, where in fact actually we may see better toxicity profile and great efficacy of ibrutinib plus venetoclax. I think the Captivate data set really provides reassurance that we can use ibrutinib plus venetoclax safely. And data set presented here at EHA, I believe the median age on the Captivate study was 61. That certainly does reflect that younger, fitter CLL population and also includes high-risk patients with deletion 17p or TP53 mutation, which personally I find that to be kind of the most appealing group to think about using ibrutinib plus venetoclax combination. So I think it's going to be helpful from GLOW to get the approval. I think we're going to then be able to use the regimen, hopefully in the younger patients with high-risk disease. And so it's, again, great to have these options for CLL patients. In particular, this was an all-oral, all-novel agent combination, so sort of a first of its kind in that respect, since other options like venetoclax plus obinutuzumab are great, but they do involve an infusional component.
You've got quite a nice group of drugs now using in combinations. is there a role for the novel therapies? There's still some interesting data coming out on them, and then further down the line, where might cell therapies fit in? Because it's not curative yet. You're curing some of the patients. You're not always sure why, but that this disease does keep coming back. So, what's your take on some of the novel therapies and the kind of the promise of cell therapy in the future?
Yeah, I'm certainly very excited, and I think that there will be an important role for these approaches because particularly as you think about using drugs like Ibrutinib and venetoclax together first. If you do have patients who progress on that combination, we don't have too much available for those patients. We can think about using PI3 kinase inhibitors. We could go back to chemoimmunotherapy, although I'm not optimistic that that's going to be very helpful. So, I think very quickly, if someone has had I plus V and relapsed quickly, and maybe we could try I plus V again, but in some patients that's not going to be helpful. I think that's a situation where starting to think about a cellular therapy approach right now in a clinical trial, but hopefully eventually in practice is going to make a lot of sense. The other drug I'm very excited about is Ibrutinib, which is the newer non-covalent, reversible inhibitor of BTK. And this is a drug that's shown outstanding activity, even in patients who have progressed on a first or second generation BTK inhibitor and venetoclax, so so-called double refractory patients. We're still seeing very high response rates with Ibrutinib with excellent tolerability. So I think that drug initially is going to play a very important role in this relapse population post initial BTK inhibitor therapy. But eventually also Ibrutinib is the type of drug I think that should be explored in earlier lines of therapy as even a preferred option potentially.
And a final note on kind of therapeutic news coming out of both ASCO and EHA around MRD, clearly an important tool. What's your take on where we are and some of the technologies that community hematologists really should be using in practice?
So MRD is already there when it comes to prognostication, I would say. So, if you have patients who are very interested in knowing how long of a duration their remission is likely to be, the end of therapy with time-limited treatments like venetoclax plus obinutuzumab, I think MRD is already a great tool to help predict that. But I would say right now it's not necessarily sort of informing true clinical decision-making. In the sense that I think it will soon. So, other studies like the MRD cohort of Captivate and several of the other studies in development are actually determining the duration of therapy based on MRD tests. In other words, if patients have detectable MRD after a certain amount of time, they would continue on additional therapy, whereas if they achieve MRD undetectability, they would stop therapy. And so I think as soon as we have these regimens that are approved that are MRD guided, then it's going to really become imperative that community oncologists and hematologists know how to use MRD to guide therapy duration. It's not rocket science, really. I mean, it's just, if it becomes undetectable, you can stop therapy. And if it's still there, you don't. I mean, there's precedents for this in other diseases like CML, where sometimes you consider stopping PKI therapy in patients who have undetectable PCR. So I don't think this is going to be a huge leap for community hematologists. And I do think once there's real utility in clinical decision-making, that these tests will be used much more widely, particularly as we now have next-generation sequencing-based testing like clonoSEQ, which is very accurate and sensitive and easy to use.
Fantastic. Let's come back to the world of social media and Twitter and round off with a couple of questions on how you've been using it. As a professional tool, what's your advice to colleagues who haven't yet made the big dive? They may have dabbled in it, but they haven't been using it really to share their news or to help educate or to kind of get stuck into some of the scientific news that's coming out very quickly. How do you approach it? And what would your advice be to kind of non-believers, if you like?
Well, I think the first thing is to get on the platform and to use it, if nothing else, just to kind of view what's going on. And I think that if you start with those kind of baby steps, you'll see that there's a lot of useful content on there. And so kind of getting used to that maybe before you start posting too much yourself is probably good to kind of get a sense for the style of Twitter and brevity and abbreviations and things like this that we often use. But I think that I would then encourage you to quickly kind of start engaging with the content. For example, there's different ways to highlight various things that you're interested in. When I started on Twitter, I would often just quote unquote retweet an important tweet just to show that I was interested in it and share it with my followers. But increasingly, I've felt like the quote retweet function is actually even better, because then you're doing that, but you're also being, you can put in a quote to provide your perspective on why you think that that's interesting and why it's important to the field. So quote retweet, I think, is a great one. I think the other thing that's helpful is tagging people. So if you're putting together a tweet and you have the limit of characters, of course. So if you run out of your characters, you can actually, separate from your character count, you can tag various people of interest. And you can tag institutions. So if there's the institution where the research is being published from, your own institution, tag the institutions, tag your colleagues who you want to see the post, because if you tag them, then they'll come up and see it on their feed. And throw in a couple of senior members of the field. In our field of CLL, I was really excited when Michael Hollick got onto Twitter, one of our most senior and beloved investigators, and it's been great to see how engaged he's been. And folks will tag him and he can engage. And what a great opportunity, especially for junior investigators, to interact with someone as experienced as Michael. So that's sort of how I've been engaging in Twitter, and it's been, I think, very helpful.
And what are some of the techniques when you're approaching some data? What's a day in the life of Twitter for you? Do you start in the morning, during Congress? How do you approach it? And you can't spend your whole life on these platforms, but what's your kind of metabolism for using these tools?
I would say I'm on the lower side of posting in terms of I know some of my colleagues I see constantly posting. For me, that's not really something that I do. I'd say I interact more on a more limited basis. I'm on there maybe 2 or 3 times a day, kind of checking in and seeing what's going on. And if it's something that really interests me, I will post at that point. But I think you have to be a little bit careful, particularly once we go back to the in-person meetings. When I'm in a session at ASH, for example, even if I'm not presenting, if I'm just in the audience, I generally like to focus on the session and kind of take it all in and take my own notes and things like that. And then after the session, I might go back to Twitter and kind of interact at that point. But I generally try to avoid tweeting during the session because I feel like for me, it just distracts me from what's actually going on. But maybe others are better at multitasking than I am, because I know some of my friends and colleagues are able to do that very effectively. But I feel like I'm not quite paying attention as well as I should if I'm on Twitter during a session.
Yeah, I've seen some of the guys on the podium actually tweeting when they should be speaking. So it's been a strange one to see people very distracted like that.
That's right.
I wonder whether you could kind of wrap up in terms of on the social media platforms. So I've got somebody calling me there. Social media platforms, on how you like to engage with colleagues outside of Congress. I think we've been seeing some of the trending. What are some of the platforms that you can use and kind of highlight some of the great papers coming out that might not be noticed?
Yeah, so I mean, I don't necessarily do too much outside of Twitter. So even between Congresses, Twitter has been my main platform, and I'm always going to put up a new article that I've been involved with, so that people are aware. I watch out for others' articles, and as I said at the beginning, that's often the way I find out first now about newly published papers is from Twitter, which is helpful, and then sort of immediately getting some feedback from others and being able to provide my own feedback. Sometimes even before I've had the chance to fully read the paper, I may see a few thoughts that people have. And then when I go to actually read the paper, I think it's very helpful to have some of those perspectives in mind. I would caution folks against using Twitter exclusively to look at paper. Sometimes like an abstract may go up or a key figure. You do have to go and actually read the paper itself, because often the devil is in the details. So that's personally something I try to be careful about. I try not to make comments on papers that I haven't actually read yet. I'll go back and read it first and then go back to Twitter and try to make some meaningful comments. But I think it's great to have this conversation. It's a real level playing field. Anyone has the opportunity to state their opinions on Twitter, and it's a great way to make connections and even to foster new collaborations with colleagues around the world.
Yeah, I think that's the key. It's such a nice tool to connect internationally and kind of meet people that you may not in the kind of normal walk of life interact with. Matt, it's been great. Enjoy the rest of EHA. Hopefully there'll be some cool stuff coming along. And of course, we're looking later in the year to IWCLL and ASH. I know there's going to be some important data coming out then. So we'll connect again, and we'll be retweeting and watching you on Twitter, and hopefully kind of sharing some important news in the months ahead. So thanks very much, and we'll see you very soon.
Sounds great, Charlie. Always great to chat. Take care.